All right, I have begun the recording, and as soon as Phil jumps on, looks like he's here. So Shane, how many folks do you?
Good afternoon. This is Phil.
Hey Phil.
Right now, it's just going to be Harris and I. I think our CNO may be joining us here shortly, and then two of our clinical consultants from Leidos will be. They're going to try to join, but that's one of them cannot. So that's why we're recording the session so we can put them later.
That's good. That is great. Well, if we've got everybody, we can go ahead and start if that's good. Let me.
Yeah, that's good.
Do a couple things here. I'm going to turn off my Outlook so that when I do the presentation for you guys, you don't see my emails popping up. All right, hopefully you guys get there we go. Do you guys see the PowerPoint presentation on the front?
Yes.
Good. Well, my name is Jim Hogue. I am with HASA, and with me is Phil Beckett. Phil's our CIO.
Hey, good afternoon, everyone.
Hi, Phil.
Hey, how are you?
And I know Shane's been talking with Phil for a while, and Shane was at out in Abilene when we had the West Central Texas regional discussion. And so hopefully today what we can do, I'll try not to be redundant with you, Shane. I'll try to do a quick reset of kind of the basics of what we do, but hopefully we spend most of our time really looking at the demo and what our products are and the different tools that we have, if that makes sense to everybody.
Yeah, that's fine. I think that maybe, on the overview, of course, you and I had spoken in Abilene, and y'all have come a long way as far as your relationship with THR and moving into the Metroplex. So I think that that's the big benefit to us, as well as some of the quality measure reporting that we can do. So I'll let you go and kick it off.
Yeah, sure. Well, and I always saw Shane. I saw you guys as really a unique fit in that when you were in Abilene, I realized that you have connections west of you, but there's a lot of value east of you as well. So my thought was is that we would have some quick discussion about what that looks like, as you mentioned, in the Dallas-Fort Worth area. Just to have a quick level setting for everyone. As an organization, just so y'all can see, the details are less important to go through. Just we built a timeline just to help everyone understand how HASA has grown as an organization. We started in San Antonio, began sharing data in San Antonio when HASA received the ARA Technology Grant 2011. And over the course of time, as a public HIE, we have grown from San Antonio and into the Corpus Christi region. And then when INTAP left the HIE world in 2015, we were asked and accepted coming into North Texas to provide the public HIE services for the community. And then for several years we had a grant to do a study in West Texas out in the white space, and have been working with folks out there, and Hendrick decided to come on, and so that's what kind of created for us an anchor for West Central Texas. So Now as a not-for-profit, we're not a analytics software company. We are a community not-for-profit whose really intent is the mission of data sharing for whatever your community needs are. We are now up to about 16 million patient encounters. We've got over 4 million unique patients. We're a central data repository, so it is not a simple federated model where you just get one patient's info when you make one request. Not only can we provide a bidirectional interface back into your EHR, but you also have the ability to do reporting and do analytics for your patients from within our community data repository. And Phil will talk to you about that in a little bit. I'm sure you guys know where you're at in your community and how you fit so closely to DFW and in between the West Central Texas service area. This is where, we are live or very close to live. We've got a lot. We are really starting to build our data here. You can see on the left-hand side in blue is our North Texas. We have all of the Texas Health hospitals. We've got all of the Texas Health physician group physicians. We've got Heart Place live with us now. We've got Envision Imaging Centers live with us now. We're live with LabCorp for the lab data feeds. And so very quickly, we are very close with Hunt Regional, Hunt Medical, Texas Colon and Rectal, Me Doctor, Me Kids, and MD Family. One thing to note that I just wanted to say, because they don't quite fit into our regions, is that out in San Angelo, we are going to go live next week with West Texas Medical Associates. They've come on even though there isn't a hospital in their area, because we got approved as a qualified clinical data registry this year to provide macro reporting for physicians. And because we do that for our cost of being part of the HIE, they were able to, aside from the technology fee up front, about break even on their registry cost with us, and that they get the benefit of the HIE data. So that's not on this list because it doesn't fit that geography, but we'll quickly add to that map. One thing I wanted to, you guys know with THR, I talked with Shane about the different facilities that aren't THR back in the spring when we were in Abilene. These are the non-THR locations that are live or about to be live up in the North Texas, West Central Texas area. A couple of things for you guys, and this will be new for Shane also. I wanted to create a service area for you guys to look at. Over the last couple months, Prosper Waco, the city, they came to us and said they have some specific use cases as a community, and they wanted to think about building some analytics. And the first vendor they went to was too expensive, and they came to us because we can do it, and there's value as a public HIE as well, because we'll have data around them. So, here you can see where you guys are, but we're also engaged, with the city of Waco. For them, it would include their regional MHMR, Providence Health, Baylor Scott White Hillcrest, the city of Waco, Waco Police, McLean County Sheriff, because the jail has an EHR. So we are talking with them about trying to stand up what would be immediately a community HIE, and they have some foundation monies through Prosper Waco they're trying to coordinate. So the only reason I brought that up for you guys is so that you guys can see how the community around you could be quickly building here over time. Another thing, since we talked, Shane, as it relates to THR, MedStar in Tarrant County has verbally agreed, and so we're in that project phase now of doing an EMS integration with MedStar. The goal, THR has said to us, they want HASA to connect all of the EMS vendors that we can into the HIE, and they're going to use HASA to do that. MedStar uses Cloverleaf to translate their NMSIS data into connectable data, HL7, et cetera. And in our discussions, Cloverleaf has agreed verbally for all of North Texas to use the MedStar connection with us as an EMS hub and connect all of the smaller EMS organizations from a data perspective, potentially with no upfront cost on our side. So that's another thing to consider for you guys out. If you've got these small ambulance systems, if they have an EHR in their ambulance systems, we may be able to do some EMS integration with them. And for you guys, it does several things. One, when they're out and they arrive on a scene, they're going to be able to, if they are connected, to search up a patient in their EHR, and potentially, if you guys are connected, they'll have all the patient information on that's in the HIE available to them then. So things from problems to meds, allergies, recent encounters, which will be helpful for them. But the integration will also begin to share data back into the HIE so that an ED could have the clinical information on them before the ambulance gets there. An additional component to that is not simply clinical is that Cloverleaf has the ability to create an EPCR, or the digital run sheet, so that all of the processes that I know the hospitals have in ED with folks, chasing down run sheets, as it relates to billing and as it relates to the registries, Cloverleaf says they have the ability to potentially create an electronic PCR for those hospitals that'll get there 100% of the time in an automated, not a manual process. And there's potential that data that comes back in the EMS interface might be able to automatically populate into your registries. So we're early on that, but there's a potential real help, not just from the HIE perspective, but for all your folks that run, chase down run sheets and deal with all your registries. So that's a new thing for us. Why HASA? As I mentioned before, we are a centralized data repository. So I know, some of the Care Everywhere out there has a whole lot of data available to you guys. And it really just does connect with Care Everywhere. There's a lot of data. But it is individual, one-time patient request, query, and pull back in. And whereas we have the ability with the centralized model to do alerts to doctors on admission, we have the ability for doctors' practices, if any of their patients were admitted to your hospital or any one of the hospitals connected to the HIE, the doctors could get an alert the next day. And Phil can tell you a little bit about that, but it's part of the uniqueness of the tools we can use when we have a central data repository. And Phil, maybe you may want to talk a bit about that, and maybe I need to hand that over to you here. I'll let you do this.
If you want to go to that next slide, Jim, yes. We can. Yeah, just put it on that next slide there. And
is that it?
Yeah, and I can definitely speak to this, and then we can jump into. Yeah, it's perfect. We can jump into showing this. But we start off in the top left-hand corner with our clients. So that's where we're getting data from. The EHR, the CCDs, ADT, lab radin path, that all comes into that green balloon, the HASA facts. We have our master patient index, so we're matching, your patients from Palo there as well. So we'll standardize normal things, simple things like patient sex, all to female and all to male, or to unknown, patient race, ethnicity, but also encounter type, financial class. So when you look at report systems, and we're not dependent on what everybody's individual data looks like, we keep all the raw data, but we use the normalized data in it. Out of that, you can then view that data. So we've got the clinical view, so that we have a viewer, the virtual health record, which I'll show you, but also ideally the integration is directly back into your system. So you query us for a CCD, we generate those on demand. So we pull that out of all the clinical data that we've got. But through our APIs, we have opportunities to limit that. So if there's specific templates that you want out of a CCD, or, clearly you don't want your own data back, so we'll exclude that. But if there's other things you want to whitelist or blacklist or time period, again, we have a lot of control over to customize that. And then you get that right back into your record where the clinician can view it without ever leaving their own system. Or say we've got our clinical viewer, we support single sign-on as well, so you don't have to log on. You can click through and view the viewer that way. The purple bubble, which I also want to show you pieces of, out of HASA Facts, you can run these reports. I'll show you some of those, like a readmission report, a quality report on the macro measures, and also one on the LACE report, which is more predictive of a patient's risk of a 30-day readmission or death. But those reports are somewhat static. You can see they're dynamic in the sense that they get updated all the time, but they're static in the sense it's hard to do anything with them. So we've got this HASA Care platform that enables you to turn that into a campaign. So for example, based on gaps in care, if you want to look at, hey, these are all my patients who need a colonoscopy, I can blast that out to the patients, send them a message, and we can do that through the HASA Go account, which is our portal, or right through the HASA Care platform as well. I can just send the patient a text message or email to notify them, hey, you've got a new message. So the patient can then respond to that, say, I had a colonoscopy, or I need one. So if you need one, that can drop then within the HASA Care platform into a closed loop referral, or we can also capture the patient entered data through there. And we're just finishing this off now. It's not quite live, but get that data back into HASA Facts in the next few weeks. We'll have that, so that then updates. So say, for example, flu shots, who had one, who didn't. If the patient says they did, we'll store that as patient entered data. Then when you run your analytics, you can see that the patient said they had one. We can also include that if you want it in the CCD on demand as well, so that you get it directly back into your own system. And then the last piece really is this patient portal that we've had a while now, but where patients can access their community record all through one place. We are also working with public that we're looking at ELR. They've asked us to do electronic lab reporting. If you don't already have a direct feed to them, do that through our tumor reporting. Also, we're connected to other HIEs. Currently, we're connected through HIE Texas to Austin and Houston, but we're working on this patient-centered data home, which is more specific, which means we send an ADT to a partner HIE for patients that live in their zip code. So we'll keep a cross-reference of zip codes. And we can communicate. We're looking at joining the central hub, which is covers Oklahoma, Kansas, and a lot of our neighboring states as well, and eventually the whole country. So being connected to HASA gets you connected to your patient data wherever they go. questions? Or before we jump into the demo, Jim?
Yeah, do you guys have any questions? And then I can turn it over to Phil.
No, we're good. We can go on with the demo.
It all makes good sense.
All right, Phil, I've made you the presenter.
Let me go. Actually, so what I'm going to show you first. So this is our virtual health record. So this is in that green balloon, sitting on top of that green bubble, or that green balloon that I showed you on that slide. And so this is the crudest way to do it, is for me to log in here and then look up the patient. And ideally, we've done single sign-on and passing context as well, so that you're not re-looking up this patient. But I'm looking up a test patient here, so you have to, I don't know, the test patients don't have a whole lot of data on them. The real patients do, but I can't show you those. I pick the patient that matches. It takes me through an attestation process here. One click gets me through there. But then this is divided up much like a clinical chart, but we've got this basic information here. One, it's showing the community gaps in care. So as far as HASA knows, we're getting clinical data from hospitals and clinics around, so should have the best data on the patient, what they're missing from a quality perspective, and the patient's basic demographics, their local medical record numbers. And then we've got a short list here of the patient's problem list, who reported it. There's also a residential history in here, so if patients have been moving around, we have a lot of requests for this, especially for our transient population and safety net population or homeless. And also the patient's PCP, if we know that as well. So if you need to get in touch with that primary care provider, you know who that is. And then on the side here are tabs that take you quickly into the different components of the patient's community chart. So we've got, this is again a summary of the last 10 encounters, lab, radiology, transcription reports. Down here you can dive into more details on those. But here it's given the clinical date, where it was done, who the attending provider was. If I click on here, although this is, it takes me into the original document so that I can see the details of that encounter. And the same here with lab results, radiology. You've quickly got a view here of that patient's history. At the top here, I've got filters so that I can see, if I want to change the date range, is defaulting to 90 days. But if I want to change that date to, if I want to use for the last year, for example, we set it fairly short, because typically you want the most recent data, plus it takes less time to load when it's short. You can look for a specific facility. So if I just wanted to look for a hunt here, it's going to give me back those. If I wanted, it's not going to give me anything because you didn't have any data on this patient. So that's our clinical viewer. It displays data, pretty much however we get it from CCDs or HL7 data, and puts it into this single viewable format.
But Phil, most if the hospital is doing a bidirectional interface, most of the time they'll just be pulling it back into their own, right?
Exactly. Typically you wouldn't be using this. You would be consuming the CCD right back into your own medical record system. And I assume, Shane, with that would be the plan, would it? Not to use the viewer, but to do bidirectional.
Correct.
Yeah.
Yes. Correct.
So it's much easier on your clinicians to do it that way. So this is So we show you some reports here. So this is an admission report. I'm in as a South Alamo Medical Group, actually here as my user, but here I can parameterize this query so I can look at patient. Again, you see normalized data here because we don't get it in this format. It comes in all kinds of ways, but I want to look at inpatient visits. I can filter by financial class. So for example, with Medicare, if I'm not going to get reimbursed for those, I want to look at that. I can also filter by diagnosis-related group. So if I'm interested in COPD patients, there I can also limit this by facility too. Here I've said I want to look at patients who were admitted in the last 30 days and where there were at least 2 admissions. So this runs across all our data, and it shows me I've got one patient. This is masked because this is real live data. So this is PHI. So I've got it scrambled so you can't see it. This would link out to the patient's clinical record. So if you wanted more details on that, you could go back out to that other view to see it. But it gives you the patient's name, date of birth, how they came in, and the physicians, the facility where this was Methodist Texan, any discharge notes or disposition, what happened to the patient, if the reason for the visit, if we get that, we've got the diagnosis, the patient, and the financial class here. So this gives you a quick view of what your patients are doing across the community. So, obviously you know your patients that are readmitting to your own facility, but which ones are going across multiple facilities? So maybe, an emergency in the last 7 days, who's a frequent flyer. So three emergency visits in 7 days. See if I didn't get any, but maybe that's a little optimistic. Hopefully nobody. Well, nobody's gone to the emergency room. But I think you see the functionality. So this gives you that that data. You can run this anytime. Your staff, your team would have access to these clinical reports to run that and look at your patients across the whole community. This is a quality report. So this uses the macro MIPS. So this uses the definitions used by CMS. So depending on the reporting, so this is really intended for me to look at my data before I reach the deadline, so I can see where I need to course correct. And that's where I want to come back to that HASA Care, where you can really turn this into a campaign. But you can run the report here for this date range. These are the measures that we've got built in here. But so this is A1C over 9. For my patient population, it's an inverse measure, so I really don't want people included in the measure, but it says, so I've got patients 18 to 75 with type 2 diabetes, 23 patients, so in this case, didn't have a result, so I don't know if it's over 9 or not, but it, fall into that criteria. So at 100%, I'm not going to meet that macro measure. What we do there, let me go back to this one, is in this HASA Care platform, I can do the same report. So this is going to run an API call to that same IMAT, the green bubble. So now I want to, my patients who didn't meet, I'm using a slightly bigger data range here and different organization, but this will now generate this patient population for me. So these are all the patients. If I want to exclude one because I've got clinical reasons why this patient, want to exclude from the group, I can continue this. From here, I can do patient outreach, or I can do referrals. But in this case, I'd say, your A1C is over 9. I want you to come back for a visit. Who the staff is, and then save that population. That'll send the messages out to the patients, and I can go and work that, see the responses from that, and work that group. So if I go into one that's already built, I've got here the A1C greater than 9 with the response. And this is where we'll capture those responses from the patient. We can bring them back into HASA facts, into the green bubble, where you can review that in the report, so that curates and updates that report. We can also again include it in the CCD on demand and get it back into your electronic health record, so we can really close that loop. So here, I can again message these people individually. I can message the whole group. I've got different status, where where the patient, if I've sent a message, they're waiting their response, coming back, so that I can really manage that that whole group through these tools. Then the other one I wanted, so those are, excuse me, get back on that. Those are retrospective reports, although managing my gaps in care is more prospective. Another way to use this is we've built out this LACE report, which uses length of stay, acuity of admission. They come through the emergency room, any comorbidities, and the number of ED visits in the last 6 months. So this is published information. The details are on here in the application, but this is a curve. This is from the published paper on this, that shows, for a score of 0, then the risk of readmission or death within 30 days is close to 0. As you get this, the blue bars are the number of patients that they had in their study. But as you increase the LACE index score goes up, then your risk all the way up to 19 goes up to maybe 45%. We did the same with the HASA data. What we did was we ran predictions on January 1, and then we plotted those against the next 30 days, because we had them, of which patients were actually readmitted. So this is the HASA, the data of a HASA community, that again pretty much maps, that shows, as you get up to 19 here, that the risk of readmission in 30 days is close to 45%. And so it seems to be a pretty reliable score. So back to this, I can run this report. It's looking at a lot of data, so it takes a while, but so my patients that I'm discharging today, for example, so I could just look at this for 1 day for all my patients, it'll give me a score. So then maybe those are the patients that I want to interact with. Here, the highest on this group was a case of 4. It shows you how it calculated that this patient came in through the ED. They've had 1 ED visits in the last 6 months. They don't have any comorbidities, and the length of stay is only 1 day so far. But so the risk level is low. But this is a tool you can use to focus limited staff and resources on the patients that are most likely to come back. You don't want to come back for their purposes, and you don't want them to come back because you maybe don't get reimbursed for them. So those are some of the examples, the tools that I wanted to show you.
And Phil,
get your feedback.
One thing I wanted to say about the LACE that's really, I think, is neat is, because some of the hospitals have some of those tools, but what they don't have is all of the admissions across the community when they're doing that. So, the ability you have for your patients to see a THR or Hendrick admission in that data calculation is what's helpful when you do that in an HIE.
Right, Jim. Yeah, it really. I mean, this gives you the community view on top of your own data.
I like that. Sorry to interrupt.
No. The other thing that we can do with this, we do is the API calls, so that you can consume this data back into your own systems as well. So we can work with you to build that kind of integration. Questions, or does this? I mean, I don't want to say that this is what we've got that for. It should be useful. Could I get your feedback on the value of these kinds of analytics? Obviously, we've got a lot of flexibility in here to build different things, but these are the ones we've been finding really are useful in the community.
Yeah, I definitely see that.
I think it's great that THR has gotten on board. I think it would be even more helpful if HCA in North Texas had embraced this, in that just over the last month they became one county closer to us. As of October 1st, they will own Weatherford Regional.
Yeah, I heard about that. Well, and I definitely, our conversations are with them. Dr. Burrell is their medical information officer, and he definitely sees the value of the HIE. They're just beholden to the corporate decision on HIE strategy. So whenever they get some direction on that, hopefully that'll enable us to move quickly with them, because Dr. Burrell seems to have, already see the value and love to kind of pursue that as soon as they can.
I'll continue to put pressure on them.
Yeah, that's good. Well, I will tell you, and this is while we are very early in this, but this EMS integration concept, I need to bring back to him. They have some specific, they have a vendor they use for that. But if this becomes a potential use case for them to kind of get Nashville, up and moving on it, I'm going to try to see if I could use that as a use case for them.
I had a comment or question. THR is kind of a parent of a nonprofit called CareFlight, which is an air ambulance service, but they also do ground ambulance service in outlying areas of the DFW Metroplex. I think or at least Tarrant County is dominated by MedStar. They have outlying, and they're part of it. So if Overleaf, I think you said, was yeah.
Yeah.
Hopefully they would get on board with CareFlight, because all of our transports none of our medical transports are MedStar. They're all CareFlight.
Well, and when THR decided to do this, I now have Kirk Keene is their operations, kind of their corporate VP for the western part of THR. And he's actually been tasked at the corporate level for helping to facilitate this EMS concept. So not only, we work with their private HIE, we work with their IT governance, but Kirk now at the corporate level has tasked, and so not only do they want us to try to do this in EMS integration, Kirk has said to me, hey Jim, let me know and we can go meet with these people. I'll come with. So to the extent that THR has seen this as a real strategy for them, I think anywhere they have influence, they plan on using it for this.
Does that need to be in?
What other questions or comments do you guys have?
I don't have any at this time. Yeah. Our consultants, once I let them look at this, they may have some questions for you. Outside of that, I don't have any additional.
Great. Well, yeah, hopefully we showed you at least a sampling of what it can do, and you get a sense of the power of it.
It's slick.
Yeah, it definitely has improved over time, and I was impressed enough that when I saw it met with you in Abilene, that I definitely wanted to let Harris see it and see if it's time for us to move forward.
I think Phil and I started talking about this 8 or 10 years ago. No, like
I think we did, Harris. Hey, but I'm in for the long haul with you.
Clearly.
Well, and this becomes a good strategy for you guys, especially with HCA also moving west, is, for sure THR, they have some advantage within the community because if they can bring in someone with Texas Health Physician Group, then all of that data is automatically shared within their EHR. And some of the independent hospitals, it is how do we enable our docs that are around us to empower them to maintain their independence if they want. And the HIE and our ability to do MIPS reporting for them provides, it does two things for you guys. One, it takes away that silo that these independent physician groups have in the community and empowers them to get connected with the other docs, with the hospital. They can pull that, any of the imaging that they send over to you guys, they can pull it back in. And what this does is it helps, I think, the independent hospitals to form a strategy to connect their community that, if over time they've been limited, the HIE enables that. And it empowers independent docs, which I think in these communities, for me, it is always an important value I have. Well, if there's nothing else, Shane, what I'll do is I'll stop the recording and I will send, I'll get you guys access to the recording and I'll let you guys talk with your consultants. And then would you like me to follow up with you next week?
Week after next. I'm out next week.
All right, very good. Well, you guys, you have our emails from the meeting planner, and if you guys end up with any questions or comments after this, feel free to reach out. My cell phone is actually on my email signature, so you shoot me an email, or if you have my email, then you have my cell phone. Feel free to reach out and ask Phil or I a question at any point.
Will do.
That's good. Thank you, gentlemen.
Yes, thank you.
Hey, thanks. Good to catch up with all of you. Thanks again for your time.
All right, have a good Friday.
All right, y'all
you too.
Have a great weekend.
Bye.